for S27, and then we're going on, we'll stay there for S18. And then we'll go back to S2 to do some voting. And we're live. So this is Senate Health and Welfare. We're back again on February 28th, looking at S27. So we have a proposal for a proposal of amendment on S27. Jen.
Good morning again, Jen Kirby from the Office of Legislative Counsel. Yeah, I think what might make sense, because it's been a while since we looked at the bill, is to look briefly at the bill itself, because the amendment is just to one section, and then I'll show you the amendment language. Does that make sense?
Mm-hmm.
Okay. Let's start with S27 as introduced. This is an act relating to medical debt relief and excluding medical debt from credit reports. And I won't go through it line by line, but just to remind you, what's in here is the appropriation of $1 million to the treasurer to contract with a nonprofit entity to acquire and repay certain medical debts incurred by Vermont residents who either have a household income at or below 400% of the federal poverty level, or owes medical debt that is 5% or more of their total household income. And the account is still outstanding even after the provider has completed its regular efforts to collect the amounts due. That $1 million comes from a reduction in the appropriation to the treasurer's office to redeem general obligation bonds prior to maturity. Section 3 is the prohibition on reporting of medical debt information. That's the piece we're going to look at that is struck and replaced with a new Section 3. So we'll pause over that at the moment. Right now, it just says credit reporting agency shall not report or maintain in the file on a consumer information relating to a medical debt. And it used a definition of medical debt in the patient financial assistance statutes. And that was cause for concern by some stakeholders who testified. So there's a new version that we'll look at. Sections 4 and 5 relate to what I think referred to as soft pulls on credit. This would allow those for somebody to determine whether somebody is eligible for the abolition of their medical debt. And then we have the prohibition on sale or reporting of medical debt. And this is maintains the existing language on that. All right, so the new Section 3 then. Share that. All right.
Is that going to be draft 1.1?
Yes. Draft 1.1, new Section 3. So just strikes out Section 3, puts in a new Section 3 on reporting, prohibition on the reporting of medical debt information. This prohibits a credit reporting agency from reporting or maintaining in the file on a consumer information relating to a medical debt, but we're not using the definition that was in Title 18. This instead has its own definition. I'll skip to medical debt first because that's the reason we have the definition of healthcare services. So the definition of medical debt here, it was suggested by the Treasurer's Office, and they've been working with national organizations and looking at language in other states. So this definition means a debt arising from healthcare services, including dental services, or from healthcare goods, including products, devices, durable medical equipment, and prescription drugs. And medical debt does not include debt arising from services provided by a veterinarian, debt charged to a credit card. This is the one I think you heard the most about, unless the credit card is issued under an open-end or closed-end credit plan offered solely for the payment of healthcare services. Not include debt charged to a home equity or general purpose line of credit or to secured debt. And then for healthcare services, the definition is similar to what we use fairly broadly elsewhere. Services for the diagnosis, prevention, treatment, cure, or relief of a physical, dental, behavioral, or mental health condition or substance use disorder, including counseling procedures, products, devices, and medications. So that's our healthcare services here. That feeds into the definition of medical debt. And that's it.
Okay. So I'm looking past you. Chris, you brought this to us. Solve the problem. And I know there were others who were interested in this as well.
For the record, Chris Delia, President, Vermont Bankers Association. So the language that you just heard is the result of the meeting we had collectively with the Treasurer's Office and reached agreement on that language, and appreciate the committee's consideration of it.
Good, thanks for bringing it to our attention. I know you did as well. You want to comment? Any other comments?
I'd like Attorney Davis, Leukemia Lymphoma Society. And I know we work with the Treasurer's Office. This is language from the state of Maine. We worked on that language, so we work with the Treasurer's Office. And I know based on some of the concerns that were brought forth, I think this is a good and fair compromise that I know Maine was able to work out last year that I think certainly fits the bill here.
Terrific, thank you. Thank you all for your work on this. We are not the finance committee. We have the chair here, keeps an eye on us.
Think this will come to us?
Huh? Yeah. That's good.
Does this need to go to finance, or you're just saying we're not used to the terminology?
No, this won't go to finance. I'm just saying that it's helpful to have the support of people in the room working with the treasurer to get appropriate language. Terrific. Thanks. Okay, so that's it, committee.
You want a motion to amend?
Yeah, let's do that.
Okay.
Do you have a question?
Yeah, I have a quick one,
Yeah,
too.
sure.
That's
Go
all right.
ahead.
Is it too strikeable?
No, you can.
It's not
Yeah. Go ahead.
a strikeable, so I just need to amend section 1 of SAT.
No, not at 18, S27.
S27.
Yes.
You don't have
Yeah,
it.
you have a printout.
It's not online.
I don't, all right.
Can you print out a copy? You can look at mine and.
No,
Kiki's gonna print you a copy.
The amendments are pretty boilerplate, I think, 1.7.
What was your question?
My question was, so the treasurer is gonna set up like the process of doing this, it says, the treasurer will purchase medical debt of eligible debtors. So is he gonna set up a process for doing that? Like, it is gonna be like an application process?
Right, so when he was here, he was talking with us about
How is it?
having an organization, I think it's called Undo Medical Debt.
Okay.
And they will take over all of the administration of that. So it'll clear he'll have oversight. But it'll clear his office of having a whole new
Or S.
program.
I have a small worry.
What is that?
It's not enough for me to
Okay. Then there's a
not support it, but I have a small worry that people might hear or online.
Okay, that's what's here.
So it's the implementation of the program is a little bit worried.
Yeah, and I think we heard testimony about that from the treasurer.
Yes, I think they've been doing this in a number of states at this point.
Yeah, that's it. How many states?
I think I can.
I can't say how many states. I do know that they just did it. I know the Rhode Island Treasurer came up. They're doing it.
Yeah.
Attorney Davis. Leukemia Lymphoma
Yes, he
Society.
came.
They're doing it in Rhode Island. I know Connecticut has an appropriation for it, and I know it's in several pieces of legislation all over the country. They did, I think, 4 million in New Jersey as well. And it's the same organization. They're kind of the main players and purchasing of this type of debt.
Yes, New Jersey has done it. New Jersey, I think Arizona, DC, Connecticut, Pennsylvania, Illinois.
We have one.
Okay,
Senator Cummings.
I think I know what the amendment should be.
This is a test.
That we amend S27, section 3 with the wording presented in draft 1.1 dated 2/27/25. Jan Carby at 6:29 PM. And that is the section on medical debt information. Is that what a motion? Correct.
That the motion to amend the bill. So,
I'll second.
discussion. Mr. Clerk. Uh-oh.
Mr. Penn,
Okay.
I'll call the roll. Please indicate yes or no. Senator Hart? Yes. Senator Cummings?
Yes.
Senator Douglas? Yes. Senator Gould?
Yes.
Senator Lyons?
Yes.
I was hoping to throw a no in there at the end, just to like.
No, we
a little
don't.
spicy, a little spice.
Spice.
I will now,
The vote tally is 5 yes.
Wait, yep, that's on the amendment.
okay. Now move that we approve the bill as amended.
Nice. Home run. I'll second that motion as well.
That was all in one motion.
No,
No,
Okay,
no.
we may have done it wrong in institutions.
maybe.
Okay. So now we're moving the bill
Okay. So,
as amended. Now we're moving the bill
Okay.
as amended to the full Senate.
okay, I guess I'll call the roll. Please indicate yes or no. Senator Hart,
Yes.
Senator Cummings.
Yes.
Senator Douglas, me, yes. Senator Gulick.
Yeah.
Senator Warren.
Yes.
Okay.
Okay. So, do you want to report it? I mean, yeah, I mean, it's my bill, but you gotta,
I'm one of the sponsors now.
would you like to report it?
Yeah.
Okay, but you better do a really good job. Well,
There's gonna be so much opposition.
Thanks.
Just so I have more clarity on
On what?
with this, sort of like.
No, this is it.
Clark.
This is how, yeah, but that's how you do it in the committee.
I just need
Committee
the
decision.
sheet and the
The committee
copy of the bill
decides
to take out.
That's it. You can but check with them anyway, yeah. Okay, so are we good with that? Good. I like that you're reporting it.
Jen, what's the final draft number?
Bills.
I know.
What's the final draft number?
So it's 1.1 on the amendment.
So, and to share with you that there is going to be a webinar on March sixth at 11:30 to 1, something like that, and then I'm on the panel to talk about medical debt. It's sponsored by VBSR and VPERG and the Treasurer's Office. So I'll send a note out in case you get too interested in your vacation and you want to do something fun.
Sounds good.
Okay, thank you for that. That's a good bill. I think it sends a message about how important it is to help people get out from under. Well, let's move on. I have to go to a conference committee and I'm gonna do that, and Senator Gulick is gonna take over for S18.
Great.
And then I want to come back. I do want to vote on S28, so and I do want to vote on S18. So let's see how far we got with that. Okay,
Yes, we will not vote without you.
or you can vote and hold it open while I walk in the door. It's gonna be right here. Get it started. Okay. Make sure that's that could be.
Right.
All right.
You guys have been very quiet back here.
Okay,
It's worked in my benefit.
Go ahead.
Definitely.
Get going. Okay, Senator Hart, we're still alive.
All right.
Go ahead.
Yes, so, Jen Kirby, would you like to take us through S18,
I
please?
will.
Thank you so
Yes.
much.
And there is it's a strike all amendment. I think you have, some of you have printed copies. So all of the changes from the bill as introduced are highlighted and bold or struck through. This language is proposed by the stakeholder group that is the health department, and Lauren Lehman is online. And other stakeholders who are interested in opening birth centers or licensing birth centers. So section 1 is the chapter on birth center licensing. Starts out with a number of new, actually it should be definitions now. So as used in this chapter, birth center means and so instead of the existing definition in the bill, it's a new definition. A facility, the primary purposes of which are to provide midwifery care, low-risk deliveries, and newborn care immediately after delivery for a stay of generally less than 24 hours. The term does not include a facility that is a hospital, is part of a hospital, or is owned by a hospital, a facility that is an ambulatory surgical center, or the residence of the individual giving birth. A number of new definitions as well. Certified midwife means a professional licensed in accordance with the subchapter on advanced practice registered nurses. Change of ownership means a change in the majority or controlling interest in an established birth center to another person. And the definition of person from Title I is includes both natural person and corporation partnerships, etc. Corrective action plan means a written strategy for correcting an issue of partial compliance, deficiency, or violation of this chapter or rules adopted pursuant to this chapter. Licensed maternity care provider means a licensed provider whose professional scope of practice, as established under Vermont law, includes pre-conception, prenatal, labor, birth, and postpartum care and early care of the newborn, and who may be the primary attendant during the perinatal period, perinatal being the period before, during, and after birth. Licensed midwife means a professional license in accordance with the licensed midwife statutes in Title 26. Licensed provider means an individual licensed or certified in Vermont to provide specific healthcare related services within a scope of practice defined by licensing statutes and rules, and may include certified nurse midwives, licensed midwives, advanced practice, registered nurses, physician assistants, naturopathic physicians with a childbirth endorsement in accordance with the law, doctors of nursing practice, and physicians. Section on licenses, we've kind of combined with many of the provisions from the license requirements section that was later in the chapter in the bill as introduced. So a lot of this is not new, but just moved. So it starts with no person shall establish, maintain, or operate a birth center in the state without first obtaining a license or the birth center in accordance with this chapter. A birth center may be independently owned and operated by a licensed maternity care provider. In the earlier version of the bill as introduced, it was specifying a couple of provider types, but this is using a larger new definition of licensed maternity care provider. No person can represent themselves as a birth center or use the term birth center in their title or advertising, publications, or other communications unless they have been licensed as a birth center in accordance with this chapter, and the license is not transferable or assignable and can be issued only for the premises and persons named in the application. So most of that is just moved up. For the application still has to be made to the Department of Health. There aren't necessarily physical forms anymore, so it's updated to say in the manner specified by the department and include all information required by the department. The licensing fee here is expanded. So each application for an initial license specifies renewal of a license or change of ownership must be accompanied by a fee of $250.
Finance is going to
Yeah. Fees go into the hospital licensing fees special fund and are available to the department to offset the costs of licensing birth centers. This takes out the language that requires the health department to deem a licensed birth center that is currently accredited by the Commission for the Accreditation of Birth Centers as satisfying the requirements for renewal. So they would have to go through whatever the department's renewal process is. There's not deemed renewal. License requirements. Again, a lot of this moved from this provision up into the license, what is now license and prohibitions section. So upon receipt for an application for a license and licensing fee, the department must issue a license if it determines after an inspection conducted by the department or its designee that the applicant, and then it just says, is able to operate a birth center in accordance with rules adopted by the department. Some of these minimum standards have been moved to other parts of the section, and the rest of this has been moved up to the license. Well, a lot of this has been moved to rulemaking or into the license statute. Revocation of license and a hearing. This amends the language in the bill as introduced, which, as we discussed at the time, was modeled on the hospital licensure statutes, which admittedly are themselves a bit outdated. So it has some updated language that recognizes more how the processes work these days. So it has the Department of Health, after notice and opportunity for a hearing, gives them the authority not just to deny, suspend, or revoke a license, but also to condition a license. As far as the hearing process, it takes out language about the usual and customary rules provided for such hearings, and instead specifies that the hearing would be held in accordance with the rules adopted pursuant to section 2359, which is coming up later of this chapter, and specifies that they are not subject to the contested case provisions of the Administrative Procedures Act. For as far as an appeal, this allows and continues to allow an applicant or licensee or the state to appeal, but sets out a different process that aligns more with the language in the general statutes applicable to the Department of Health. So it's appealed in accordance with section 118 VSA section 128, and then pursuant to section 129, an appeal does not stay the effectiveness of an order entered by the department, but a party is permitted to seek a stay order in the Superior Court where the appeal is being heard. Okay, so updating the language. Inspections. This directs the Department of Health or its designee, I believe the Department of Disabilities, Aging, and Independent Living's licensing and protection unit does the inspections. So that's likely the designee, the department or its designee shall make or cause to be made such inspections and investigations as the department or designee deems necessary. And it has a different process here, although it does still have a report if a violation is found. So this is where we move the provisions about a birth center, including its buildings and grounds, being open to inspection. This adds, and in accordance with applicable law, its records are subject to inspection by the department and its designee at all times. And this adds that if a birth center is found to be out of compliance with any requirement of this chapter or its rules, the department can condition, deny, suspend, revoke, or refuse to renew the license or ask the birth center to develop and implement a corrective action plan. And then if the department finds a violation as a result of an inspection or investigation, the department will post a report on its website summarizing the violation and any corrective action required. No changes to the section on records and confidentiality. Number of changes in the rules section. So it still has the health department adopting rules to carry out the purposes of the chapter. Instead of the rules aligning with the regulation or aligning with the standards published by the American Association of Birth Centers, instead has them based on those standards and says that they shall, at a minimum, include provisions regarding a number of things. Requirements for operating a birth center, including requirements for safety, sanitation, and health. So that's where those provisions were moved to. Obtaining, storing, and dispensing pharmaceuticals consistent with state and federal laws. Requirements for notice to the department when there's a change in ownership of the birth center and any additional licensing requirements related to a change in ownership. Still includes language about the scope of services that may be provided at a birth center, but it adds including risk factors that preclude a patient from receiving labor and delivery services at a birth center. Appropriate staffing for birth center, including the types of licensed providers, just using consistent language here, who may practice at a birth center. Here's where we've added in the birth center complaint processes, birth center facility, equipment and supply requirements, including requirements for maintenance of safety, sanitation, and health, record retention and confidentiality, quality assurance and improvement, processes for the development, submission, approval, and implementation of corrective action plans. And then from the bill as introduced, a requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital if the circumstances warrant. Made some changes in the no effect on scope of services language. So first, nothing in this chapter or its rules shall be construed to, and under the bill as introduced, it said limit. This adds or limit, expand or limit the scope of the services that a licensed midwife, certified nurse midwife, or other, other provider may offer at a birth center or perform in a space that is shared with or adjacent to a birth center. And a birth center may serve as a location, this is new, for additional services offered in shared or adjacent spaces, including outpatient gynecologic care, primary care, and education and support services, provided that any licensed provider providing services in those spaces shall only provide those services that are within the licensed provider's authorized scope of practice. Section 2 is the health insurance coverage provision, and the change here is to specify that the coverage for services provided at a birth center must include birth center facility fees. Section 3 continues to be the exclusion from the certificate of need laws for a birth center, not have to get a certificate of need. Section 4 continues to direct the Agency of Human Services to seek federal approval to allow Medicaid to cover services provided at a licensed birth center and to allow Vermont Medicaid to reimburse separately for birth center services, again, including the facility fees and for professional services. Finally, the effective dates, the act will take effect on January 1st, 2027, which is a different, I think it was 2026 and the bill is introduced, but this says 2027, or the effective date of the birth center rules adopted by the Department of Health, whichever comes first. So it gives them time for rulemaking, except that the Agency of Human Services must submit its request for Medicaid coverage approval by July 1st of this year, and the coverage will begin on the later of the date of approval or 2026. Although there may be nothing to cover until the rest of it.
Thank you so much, Jen.
Yes, I have to look at, now that I'm reading this, it doesn't really work because we need to have the act itself taking effect earlier, at least this section. So I will flag that for myself.
Okay.
Interestingly, the effective date section to take effect before anything else.
Right on. Thank you. I know we want to hear from OPR, but I
It's actually Board of Medical or Vermont Health Department.
okay.
It's
Vermont's right. I'm sorry, Vermont Health Department. And I, because Lauren used to be at OPR. I think Sam has a question. Senator Dunn.
I didn't realize that we had more testimony.
Oh, okay, thanks.
All right. Yeah.
Go ahead, Lauren.
My name is Lauren Lehman, from General Counsel for the Department of Health. I don't have much to say today. I'm here just to answer any questions, but I did want to say we would support the bill as amended and thank the Vermont Birth Center Coalition and for working with us on these amendments. Thanks.
Thanks, Lauren. So Senator Douglas, would you like to ask a question?
Yeah, so page 1, and this is something you and I actually talked about, and I spoke with Representative Black about it for reference. So the term on page 1 for the new amendments, the term is not include facility that pays a hospital that is part of a hospital or owned by a hospital. Is there a willingness to strike out the words "is part of a hospital" or "is owned by a hospital"? Because being able to allow them to be on the grounds of the hospital would be very helpful for having transportation to that hospital. They're not, it's going to maintain the exact footprint of a birthing center that's not in the hospital grounds. It's going to be, it does everything that you want it to as a birthing center. Just this would allow a hospital to have one if they so choose.
I would look to the Department of Health since they license both.
Lauren, did you understand that question?
I do. Thank you. This is Lauren Lehman again. I do not have the Department of Health does not have strong preferences regarding that. I do believe the Vermont Birth Center Coalition, that is a request, and it's also consistent with the American Association of Birth Centers language in their model rules. So I defer to them on any comments or questions on that topic.
Yes, I'm gonna ask if Shayla Livingston would like to speak.
Hello, everyone. I'm Shayla Livingston. I'm a member of the Vermont Birth Center Coalition. So the reasoning around this, again, like Lauren just stated, it is in the model regulations. We want to differentiate between a hospital birthing unit. And keeping these separate is what keeps the practices and evidence around how natural physiological birth happens separate from what is more traditional hospital birthing unit practices. And what they've found is that when hospitals own these units, they tend to not last as long, close faster. They're not money makers, as we've all talked about a lot in this committee. And so I think that the idea is not to make them adversarial to hospitals, as we've said many times, and having them close to or near a hospital or sharing hospital grounds, it's fine, but when the hospital owns it and controls it, it impacts the type of care and the manner that women experience care in the facility.
Yeah, I think that's the reason why the word freestanding is part of the word, right?
Yeah, it's freestanding
Yeah, and that's what I'm talking about. I kind of mean more like
on the ground.
on the ground, but I mean, okay.
I don't.
No, go ahead.
Chime in. I guess I would ask any lawyers sitting in the room because I agree with you, it'd be really great if there was a situation in which a hospital wanted to invite a freestanding birth center to be on the grounds. That would not ever be something we would want to exclude. And so I'm hoping that the language would allow that as written, or if not, we could allow that to happen. Because the birth center would have to rent or whatever, own the building, rent the building, lease the building. But I don't see why that we would ever want to exclude that from happening, like you're saying. So.
Right. So I suppose when I say striking out is part of a hospital, I didn't mean like it was going to be inside the hospital. I guess I meant like part of a hospital complex.
Yeah. Okay.
Like, don't get me wrong, like, no, I agree with it being freestanding, separate building. That's not what I'm talking about, having it be in the hospital itself. I just mean to be like
What if
part
we
of the
say
hospital
a
complex.
birth center may be located on the grounds of a hospital?
Or part of a network.
Part of a network, yeah.
I think that gets confusing about ownership, and I'm not sure if we want to go there, but can I consult with the health department? See if Lauren is amenable to language saying it may be located on the grounds of.
Yes, this is Lauren Lehman, for the Department of Health, and, the Department of Health does not object to that change.
Yes, Senator.
Thank you, Madam Chair. As there, Vice Chair.
Yeah.
Yeah.
All good.
All good. So the other thing, and this is the only other thing I have is, so we did hear testimony that it is ideal to have freestanding birth centers within like 15-20 minutes. What we do at a hospital in case there's emergencies or hemorrhages, is that something that could be included in the bill? And I see two different places for including that.
Yeah, go ahead.
It's definitely in the rulemaking.
Yeah, I would, I will,
This is Vermont, it's a relatively small state, so like 20 minutes is a fairly wide
Yeah.
radius from all the hospitals we have. That's a lot of area to cover.
thank you, Senator. I will defer again to our folks in the room who would have more information on this.
Sure. So Shayla Livingston again, member of the Vermont Birth Center Coalition. So I think I really want to drive that no midwife would want to open a hospital or a freestanding birth center. Excuse me. That's what you said. A freestanding birth center in a scenario that was unsafe. And I think one of the things that we experienced just having this meeting with the health department around the amendment to the bill that stands before you is the health department is in a really good position to ensure that the regulations like guard against any unsafe circumstances for labor and delivery for women and pregnant people in Vermont. And I think when we look at placement in the state in terms of safety, the variables, like you're saying, are wide. Maybe you're close, but the road closed in the winter. Maybe you're far, but it's just highway, so it's easy. Maybe you're further, but you're closer to a tier 1 hospital with an EQ than you are, so like, I don't think that there's like a mileage that makes necessary sense. And I think one of the strengthening things that happened in this amendment is around the shall for rulemaking, where it really gives the health department authority to ensure safety. Yeah. But I want to appreciate the concern.
Any other questions from our rather small committee? Oh, there are some folks who look like they don't have to get that.
Hi, Devin Green of Vermont Association of Hospitals and Health Systems. We had discussion previously about birthing centers or birth centers taking Medicaid. And I was wondering if we could include that in this bill. Again, because the birth centers have said that they would take Medicaid, and this would ensure that no new actors would come in and only take commercial and negatively financially impact people.
Didn't talk about that.
Yeah, Ben Kirby, would you like to speak to that in terms of the bill?
It's policy, excuse me, a policy question about whether you want to specify that the bill require birth centers to accept Medicaid or not.
Can you direct us to what part of the bill this would be?
It would be probably a new provision. I'd have to think about where it would go. It may be, it may be part of the license, I may make it part of the licensure requirement.
It would give hospitals, I think, some surety. We already have private agencies taking the full pay people, private insurance out of home health and long-term care kind of there. And this would say that they couldn't, somebody just might want to set up a kind of resort kind of thing, you know, you can go to foreign countries and live in a resort and get your knees replaced, your kidneys replaced, and you know, have this kind of luxury setting. And this would say, fine, you can do that, but you also have to take the votes that are that have public insurance.
Right. Yeah, and I believe our chair is in favor of that.
Yes.
Would you like to speak to it, I guess?
Sure. So again, Shayla Livingston. So there's no other scenario except for hospitals where we require a privately owned entity to accept public insurance. So hospitals are the only ones right now. And they receive DSH payments. So they receive funding, public funding to offset the cost of providing uninsured and low or underinsured care to patients. In this case, birth centers would not be receiving that. So by requiring a private LLC to accept public insurance without providing any sort of other public support could mean that birth centers would struggle to be viable potentially. I think in place of that, the thing that makes the most sense is to raise the Medicaid labor and delivery rates. And that's something that we are working to do through the appropriations process so that it is viable. So that's my first concern that's sort of broad and stands long term. My second concern is more acute and immediate. And that is that we have heard some really concerning policies and considerations out of the federal government recently around requirements for providers who are going to provide care to people receiving public insurance on Medicare and Medicaid. So while the midwives that we spoke to and are on the coalition all very much intend to accept Medicaid, and that is why it is part of the bill that Medicaid create the fee for this and reimburse them for it. I think that we are in a moment where the committee should pause and consider if making it a requirement is a good plan. If, for example, the federal government were to ban the care of people who are transgender in places that, accept Medicare and Medicaid. So I don't know that this is the moment to do it. I think the other thing to consider is, it's going to take a number of years for one of these to open, as Ledge Council just said, with the effective dates, right, with the rulemaking and establishing, et cetera, et cetera. Once that happens, if this emerges as a problem in the future, it is something that could be addressed. Again, we don't anticipate that being an issue as we anticipate these centers accepting Medicaid. And it would be a very new space for the legislature to go into requiring private LLCs that don't receive other funding to accept public insurance. So again, intention is 100% behind them taking Medicaid. This is an equity issue. We have been making that argument all along, but we have some legal concerns with doing that.
Thank you. Other questions? Otherwise, I think I will pause and maybe go offline until our until Chair Lyons comes back, so you can vote when she gets back.
Oh, actually, so are we going to include, what Devin was talking about then with Medicaid or not?
That's why I want to
You are
pause and wait for our Chair Lyons to come back. That seems like a committee discussion.
So I am updating effective dates. That's what I've been doing right now. So let me put up what I'm thinking. Maybe that's something we can look at. And it's not a perfect markup, but pretty close. So I broke it out by sections. Section 1, the birth center licensing would have that, would take effect on January 1st, 2027, or the effective date of the rules, whichever comes first. Section 2, the health insurance coverage, I think we generally do coverage requirements at the beginning of the calendar year to align with the most planned years. So I put that as January 1st, 2027. That way the payers can build it into their rates. Section 3 is the certificate of need exclusion. I put that as July 1st, 2025, so that somebody could start the process and know whether the exclusion applied to them before they were ready to be opened. Section 4 is the request for federal approval. And this is where I didn't mark it up, but I suggested that this would say it would be effective on passage, and the health department would submit its request by July 1st, 2025, and the coverage would begin on the later of the date of approval or the effective date of the birth center rules adopted by the Department of Health, which is when the licensure piece becomes effective, and then the effective date section itself would take effect on passage.
Thank you,
Does that make sense to people? I can't see.
Yeah, that's fine.
I know that was well. That was artful.
Make good use of your time.
Thank you. So yeah, let's go offline, take a little break.